This is Siaya County's presentation on CSTOC implementation from the period it started till October 2021. So in Siaya County, you have 2,128 CHVs and 221 community health units that are implementing community health services, and they are fully functional. But out of that, we have some CHVs and community units, as indicated there, that are supported by partners to be able to effectively do their services at the end of the day. But in part of their work, there is a use of manual reporting tools. And as many of you have worked in service, you have the longitudinal registers, which are very cumbersome to carry, and they also to use back at the community. So at the end of the day, there was the linkage between CHV's reporting and community units' monthly commodity reports was a challenge that we could not effectively point out how best these people are working. And this non-visibility and performance on commodity use was limited up to a certain level. Thus, while trying to track the stockouts and commodity availability at the individual CHV level was something that was not possible at all times unless you go for a support supervision, and that was dependent only to the partner-supported areas. At the intermediate level, that is the community health assistant, they had also inadequate data visualization skills and use of data in commodity management. So through CSTOC, which was pegged on various areas, use of mobile technology, which generated to user-friendly dashboards, and the impact team to support the process, we were able to do and train both the CHVs, the CHARs, the sub-county health management, the county health management, and also part of the executive on the process of how we can use mobile technology to collect data, which will be used through a user-friendly and generate a user-friendly dashboard. And through meetings for impact teams on a monthly basis, you could generate information from the dashboards to make decisions on what best can be done to supply this information. So in terms of results, CSTOC has several components, as has been done. So the focus mainly is on the receipts of medicines and reporting of stock on hand and dispensed at the end of the day. So this is Siaya County's performance at the start of the project in November 2020 till October 2021 for last month. In terms of receipts, one of the challenges, as I pointed out in the problem statement, was that we were unable to see as a county at individual CHV level what each CHV is able to receive. So at the start of the project, the receipts was as low as 32%, and I said we were at 2,138, and we could only effectively see 620, so we had an incremental reporting from 32 to 53. And stock on hand and dispense was improved from 41 to 79. The disparity between the two, despite being one CHV, is pointed out at when the stock on hand and dispense is being reported, they have physical meetings in which they actually report what they have at the time they are doing the report. But the receipts is only done once the reports, they receive commodities from the facilities. So that is why there's a slight difference between the two. We have 6 sub-counties in Siaya, Elegu, Songa, Bondo, where I work, Game, Ugunja, and my colleague Ugenya is also represented here, and Rarieda. So we have as low as 27%, but there's an incremental up to 81 for the reporting month. We have 55 who are there at Ugunja. We also have Bondo, which was the highest from 39 up to 93 or 88 from the graph. But what it just points out is that we are able to see effectively that if there's a forum, if there's a platform for people to report and see where the commodities are, because one challenge that was always there, a particular community unit will not offer community health services because you don't know whether they have those commodities or not. But if you're able to see what they have in terms of stock on hand, and if they have dispensed, means that a service was offered, a life was saved at the end of the day. So the receipts offer a very different perspective, just to show whether the intermediate supervisor at the facility are offering these commodities to the community health units. And you also have the various sub-counties. And the big spike in April shows the supply of commodities from maybe KEMSA, because also KEMSA supplies on different dates. And this availability also goes down as commodities also get stocked out from the facilities. So the receipts just shows that at some point in time, there is maximum availability and maximum supply to the community health units. And some point, there are some sub-counties in which you can effectively monitor at the county level and be able to know which sub-county is able to offer these commodities to the community, which sub-county is not offering these commodities, and what are the reasons, and what are the impact teams doing about it. So these are just some of the community impact teams, which I won't go so much into because there's a portion for that. But it just shows the confidence and also the commitment that the community health units had on at every day on the 28th of every month, that they'll be able to do that. I think I was avoiding that side so that he does not show me that time is up. But thank you for that. I'm nearly done. So this is a very important slide because it's just explaining what worked well and what are the challenges that were showing up. The use of TOTs from the top level up to the bottom level, that is at the CHV level, was able to cascade the information. We saw more of the CHVs reporting so that we could be able to see who has what. The sub-county WhatsApp groups worked very well to show about troubleshooting. The community impact teams, as compared to the sub-county impact teams, worked well. In contrast to the sub-county impact teams, did not work so well, but as compared to the community impact teams. But there was an improvement in terms of meeting the objectives. The child learning sessions, incorporating CSTOC as a performance indicator, use of the hard copy tools in collaboration with the CSTOC application made things easier as a comparison. What I talked about, low reporting of stock on hand and dispensed. Follow-up on non-active community units was a challenge, as I mentioned in the problem statement. There are some that are supported, some are not supported. So for this to go on, we need all community units to work out. This is mainly to the national program. There were several partners who have different, which was brought up when the team from the national visited us in Bondo. The issue of having several mobile applications, you can forget passwords at the end of the day. So the lesson learned, just as I finish up, is that visibility enhances accountability, resupply, and stock status of commodities. And then the inactive community health units as CHVs can be visible in terms of knowing which one is performing better, which one are doing better. And I can quote one of the CUs in our sub-county. One CHV felt that she's glad and happy that CSTOC brought the national program up to her level. I remember Dr. Salim, you were with me in that meeting, and she was very happy that her good work actually brought people to come and appreciate her. So invest in mobile technology and at all levels it makes data visibility possible at all levels. And involvement of all stakeholders from the CHV to the counter leadership facilitates the process. And child learning sessions are always a good learning forum for continuous updates. And as part of the sustainability, an enabling environment is also key in doing CSTOC, because without the political goodwill, without the leadership, without the funds, without the planning that is needed to do these sessions and also these aspects, we will not be able to succeed with CSTOC. Thank you so much.